All right, so going through chapter 20 now, we're going to hit the cardiac chapter. And anatomy and physiology is going to be greatly important for understanding how the cardiovascular system works. So, knowing the composition of blood, we're not going to go through that too much today. Go through your book on that. We can discuss it in class. But the flow through the chambers of the heart. So, I drew a box in your slide here. Sorry for the crappiness of it, but if you think of the heart like a box, it'll kind of help you get through the flow a little bit. So what happens is through the superior vena cava, which is this blue, which is right here, superior vena cava is blue because blue represents in your book too deoxygenated blood. So blood enters your right atrium through the superior vena cava. And then from there, it has there's four valves in your heart where blood can, like doors, but valves that blood flows through from one chamber to the other. But it's designed in a way to keep blood from going the wrong direction. So once blood goes from the right atrium, which is right here, okay, right atrium, it goes to the right ventricle through a tricuspid valve right here. But that valve keeps blood from going from the right ventricle back up to the right atrium. Only flows one way. So the deoxygenated blood comes into the right atrium through the superior vena cava. It goes through the right or through the tricuspid valve into the right ventricle. Then from there, it's pumped back through the pulmonary valve. Okay, so the flow of the blood comes through the tricuspid, right ventricle, and then it's pumped back out through the pulmonary valve into the pulmonary vein, which is right here, pulmonary vein. Now it goes into the pulmonary vein and it goes right and it goes left going into the lungs. When it gets into the lungs, then that's where gas exchange happens. Carbon dioxide is dropped off, oxygen is picked up, and then it flows into the left atrium. Sorry guys, hold on. Yeah, sorry, I had a phone call. Anyway, so then it comes after that. It comes back into the left atrium, which is right here. But it comes back through a pulmonary vein as oxygenated blood, which is pretty cool. So then the oxygenated blood comes into the left atrium, flows in, goes through the bicuspid valve right here, into the left ventricle, which is right here. And then from there, that oxygenated blood goes through the mitral valve and is pumped through the aorta, the aortic valve, to the body. Okay, so that's basically the rundown of how the blood flows, and you guys are gonna need to know this for test, and you're also gonna need to know it for class. We're gonna go through it. Okay, so be ready to draw it on the whiteboard for me. But again, it's very simple once you get it. It's just a matter of knowing which arteries what and which pulmonary veins, pulmonary arteries. But it flows in the right atrium, tricuspid valve, left ventricle, or right ventricle, sorry. And then through the tricuspid valve, it pumps to the body, to the lungs, through the pulmonary artery. And then it goes right and goes left to the lungs, gets oxygenated, drops off carbon dioxide, picks up oxygen, flows back through a pulmonary vein, into the left atrium, through the mitral valve to the left ventricle, and then pumps through the mitral valve. Sorry, I got those mixed up. But to the valve, and then to the aorta, and from the aorta to the body. So, yeah, know those. Only job of the heart is to pump blood. That's all it does. It's a continuous muscle, generation and distribution of electrical charges. So the SA node, AV node, okay, is all the pacemakers of the heart. SA node is the main one that we need to know about for you guys. And then mechanical response to create rhythmic and unceasing pumping action. Your heart never stops. Okay, so one of those deals, you live to be 100, your heart never stops beating, not one time, no breaks. Requires constant supply of oxygen and nutrients. Your heart is a muscle that is part of your body, and it needs a blood supply, it needs nutrition, it needs oxygen. When people are having MIs, begin having a heart attack, if you will, the heart muscle is not getting oxygen and it begins to die. So here's a breakdown of some of the anatomy and physiology of the heart. Okay, your aorta, where everything flows to your body. It's important to understand that. Left coronary artery, need to know that. So if it's on this chart, you're going to need to know it. Left anterior descending artery. Okay, so it's on the left, know where anterior is, posterior and anterior. Okay, so front of the heart, so it's left anterior descending because it's going down artery. Okay, so we'll just keep moving here. Sometimes called cardiac compromise is ACS, acute coronary syndrome. So go back for a second and look at your coronary artery right there. And then you got your left coronary artery right there. So coronary arteries are being compromised. Refers to any time the blood supply to the cells of the heart is blocked or disrupted. So in those coronary arteries, which is artery, blood flowing, right? It's important. So when they get blocked, it's going to stop nutrition, blood, oxygen from getting to the heart, causing cell death. Hypoxic condition of the heart is called ischemia. So hypoxic, what is that? Lack of oxygen, right? The patient's hypoxic is because they're not getting enough tidal volume and good oxygen. Now the heart's not getting it. The heart is becoming hypoxic because the coronary arteries are being blocked, and then it causes ischemia because there's not enough oxygen getting to that muscle. That muscle begins to die. Maybe not be dead yet. It's in the process. It's ischemia. It's a process in action. Cell die quickly without adequate blood supply. So chest discomfort is best known symptom. So they can have chest pressure, feels like somebody's sitting on their chest, squeezing, like there's a vice around their heart, or just a dull ache like any other muscle. And sometimes people will have chest pain that feels like they tore a muscle. But in reality, what it is their heart muscle, not their chest muscle, not their pectoris. Can radiate up to the jaw, neck, and then either arm as well. And then also the upper abdomen. And so funny thing with women is women may not even feel chest pain, they're just nauseous. So key phrases of they feel any of these things: pressure, squeezing, aching, but then it radiates to the jaw, neck, either arm, upper abdomen. That is a telltale signs. Dyspnea is another common finding in older patients. So acute coronary syndrome, nausea, vomiting, syncope, they're lightheaded, feel like they're going to pass out or they're passing out. Sudden onset of sweating. Some of these guys, when they're having a cardiac event, they will be laying in bed sleeping and their bed is drenched instantly. Sudden onset of that sweating. Abnormal pulse, tachycardic or bradycardic. Can be either way. Abnormal blood pressures, right? Because if they're tachycardic, they're going to be hypertensive. If they're bradycardic, they're going to be hypotensive. It can go either way. Anxiety, feeling of impending doom. If a patient tells you they feel like they're going to die, move quickly. Acute coronary syndrome, so perform primary assessment. And, everything you're going to normally do, you're going to do, right? Get your vital signs, get your history taken, get your information that you need to get, just like any other call. It's ran the same way. Get a 12 lead. If there's time, explore chief complaint. Use the onset, OPQRST, right? Onset, provocation, quality, radiation, severity, time, right? All those things are going to be critical to get. especially with cardiac events. You got to know the timing. Well, if they're like, oh man, my chest started hurting yesterday, that's a big deal. This is a whole 24 hours went by. You got to have that time. Obtain medical history. Is this a new onset, or is this based on the old onset with a new event, right? So get that, take baseline vitals. What you're going to see, pain, pressure, discomfort in the chest, jaw, and neck, like we said. Difficulty breathing. These are kinds of people, man, I walk up the stairs and I can't breathe. Palpitations. They're going to feel, I had one patient one time before they died in an event, told me they felt like butterflies in their chest and in the throat, actually. So sudden onset of sweating, nausea, vomiting. Go back. Syncope, anxiety, unusual generalized weakness, feeling just malaise, don't feel good, I'm weak. Abnormal pulse, tachy, brady, dysrhythmias, and abnormal blood pressures. Physical examination you're going to see is grabbing or clutching the center of the chest. They may be that way, The human body is funny because it will actually show you what's going on, like if you just watch it. Because they're not consciously putting their arm at their chest. You know that? They're not like choosing, I'm going to put my hand here. No, their body's doing it. Your brain is having your arm do that because that's where the problem area is protection. So they're going to sweat as well. They could be pale or gray. If you see that, that's a sign of shock. Anxious. Or restlessness. Physical exam, so acute pulmonary edema, swollen ankles and feet. Medical alert jewelry, look for if they're unconscious, unresponsive, not able to talk to you, look for medical jewelry to tell you if this is a new problem or part of an old one. 12 lead AKGs, speed up process of recognizing electrocardial findings. So even though your EMTs, you can speed up the process, like I said. So you get your baseline vitals, and then if you get 12 lead first time, don't stay in play to cause the patient to die. But if you can get 12 lead taken care of, you can speed up the process of finding the issue to be able to compare it to where they're at right now or at the hospital. Interpretations is outside your scope as an EMT. So you literally cannot document that you interpret it, but you can document that you took a 12 lead for a paramedic or a doctor's interpretation. Again, I'm a huge advocate for EMTs getting 12 leads. If you don't have a paramedic on scene with you, get the 12 lead AKG so the hospital has something in their hand to compare it to when they do their own, because time is of the essence. EMT can place the leads, acquire the print and tracing. EMT can transmit AKG to destination hospital. Take a picture on your phone and you can text it to the doctor. But the other thing is we have Pulsera now, so you can upload it right to Pulsera and the doctor can see it instantly. So good thing to do. Do not lean back just because you're an EMT. Lean forward and do the best care possible. Preparing the AKG, place electrodes on chest, and electrodes need to secure contact with the skin. Shave their body and dry off their body. If they're sweating, dry it off. If they're hairy, shave off their skin and jewelry and everything else you can find. Remove sweat and dead skin cells, and then remove hair. Yep, so clear, cut, and dry. So 12 leads, we're going to go through this in lab. But step one is place limb leads. And as I told you guys, limb leads are limb leads. They're not torso leads. They're limb leads. Place them on the right spot, right? Right wrist, right ankle, left ankle. In the ambulance, it's okay to put the limb lead of the right one not on the wrist, but put it on the outside of the shoulder. But the closer those leads are to the heart, it's going to change the pictures. So you got to be able to get a good picture. V1 and V2. So real quick, I'm going to draw a horrible picture. See? Horrible picture already. Let me get rid of that. So here's the neck, we'll say. It's going to go over shoulder, arm, torso, That arm is huge, but you guys get the picture, right? So limb leads will be somewhere either here or at the wrist, here, okay? But the sternum is right here. So the heart is where? It's right here. It's on the left side. So V1 will go on the right side of the sternum, about there. And I'll show you in labs because it's like third rib down kind of thing. You got to put in the right spot. V2 will go here. And then V3 will go wherever the nipple is, kind of thing. You go just next to it. And then V6 goes right under the armpit on the side of the thoracic. And then you space out 4 and 5 like that. So you're making a circle around the heart. And we'll do this in lab. It's not a very good picture at all, but just so you have an idea. And V4 and V3, you know, we'll get through it. Well, maybe there's a picture in your book. I haven't been through slides yet. So right arm. Yep, there you go. Perfect. I'm sorry, guys, for wasting your time there. So you kind of see what's going on there, right? So V1, 2. Actually, this is not a very good picture. I don't like it at all. Well, the main one thing is 5 and 6, right? So 6 is like you can see here, right where I said at the armpit area. Then 5, and then 3, or I'm sorry, 5, 4, 3, 2, 1, just like that. So it kind of makes this little wave around where the heart is, because the heart's behind this chest right here. And so it gets this great picture that we'll go through in class. So fundamental principles is place patient in a position of comfort. Let them take care of themselves. They know where they need to be. Determine if oxygen should be administered. So you're getting your baseline vitals. So put them in position of comfort, know where their oxygen levels are. Sometimes they need oxygen, sometimes they don't. Respiratory failure would be a sign, as you're going to see agonal breaths. They're apneic, which is breathless. There's no breathing at all. Should receive high concentration oxygen via ventilation. So if you got agonal or apneic, you're breathing for them. Determine if oxygen should be administered. So low oxygen saturation, you know that. No significant distress and oxygen saturation of at least 94% should not receive oxygen. We'll go through some anatomy physiology stuff, but oxygen can speed up a heart attack. So it used to be old at school is give everybody oxygen. Not at all. If they're not destatting, oxygen is not necessary. Fundamental principle of care, if trained, equipped, and authorized, do so. Obtain a 12-lead AKG program, and then follow local protocols as to whether to transmit it to the hospital for interpretation. We'll go through that as well when you guys are EMTs. So administer 325 milligrams of aspirin by mouth if allowed. It is allowed, 100%. If you're different than paramedics, okay? So as a paramedic, we're going to get full set of vitals, and we're going to get an AKG before we give aspirin. You can't interpret the AKG, because by AKG, I can tell this patient's ischemic changes or in a cardiac event right now. So they're having a MI or they're having an infarction. We can tell that by reading 12 lead. You can't. So in my scope, we're not able to give aspirin unless we can prove it needs it. You guys, if there's chest pain involved and you suspect a heart attack, give 325 milligrams of aspirin. We carry 81 milligram tablets, so you're going to give up to 4. Indications for not administering aspirin is if there's risk aspirations, they're nauseous, give some Zofran. Get IV access on these patients, and you can push Zofran on board to help with that nausea. But if you think they're going to vomit, don't give it. They've already taken a full dose on their own. Some guys already have, if they have a history, they're taking aspirin prescribed by their doctor, or they're allergic. Are you allergic to anything, right? Sample, OPQRST. If they have GI bleed problems, ladies like, man, I have chest pain, and you're suspecting a heart attack, but they also have a GI bleed, not going to give aspirin. Or if they're taking blood thinner. Like I said, ask if they're taking Viagra or any kind of erectile dysfunction medication. They can't take aspirin either. So no your drugs that you're given and know the side effects. Again, right time, right route, right patient, all that stuff's going to be important. Indications, so administered nitroglycerin, chest pain, history of cardiac problems, physician has prescribed it already, and the patient has nitroglycerin at hand. So that's at your discretion. Obviously, we don't carry nitro yet. We will when we're ALS, but we don't carry it. And then the other side is, I don't like giving nitro possibly to an MI, which is myocardial infarction, because we don't know per se right-sided, left-sided, and like that. So it can cause issues. But if they have a history of it, they're prescribed it, they have it on hand, you technically can assist them with them taking their own nitro. Systolic blood pressure meets protocol criteria. So really, if you look at criteria, because nitro is what? It is it's a dilator. Okay, so as a dilator, you are going to dilate their arteries. So what you're going to do is what? You're going to lower their blood pressure. So the main thing is you do not want to lower their blood pressure anymore, so you got to look at protocols. So one of the protocols to follow is if their systolic blood pressure is below 90 or below, I'm not going to give or consider giving nitro. Fair enough? And then the other one is patient has not had Viagra. So when you ask them about Viagra, the timeline is 48 to 72 hours, as you see there. So if they've had it yesterday and they're having chest pain day, you're not going to give nitro either. So just some things to look at. Sorry, I'm just looking up something here for you guys, actually. So yeah, I was right. Hypotension. Less than 100 systolic, you're not going to give nitro. That's our medical director here. I got 3 medical directors, so I have to look up. They're all a little bit different. Medical direction is authorized administration of medication. So after giving 1 dose of nitroglycerin, repeat it in 5 minutes. So if you watch them take it and it didn't make any significant changes, hasn't dropped their blood pressure, still at 100 of systolic, you can give another one. Again, always for test purposes, medical direction. No more than 3 doses. Treat for shock if blood pressure falls below 90. So if you gave nitro and you gave 3 doses, now you're the one that helped assist their blood pressure to drop below 100 systolic. Now you got to treat that. That's okay. I mean, it happens. We're authorized to give nitro. There are side effects. We might see those side effects. Now treat for shock. So IV, you should already have IV access. If you don't, that's another thing I would say is I would never give nitro to someone without IV access, so you can counteract what you might have to. So fluid replacement. So disorders that you're going to see: heart problems caused by a number of disorders affecting condition and function of blood vessels. So condition that narrow or block arteries often result from fatty deposits build up on inner walls. So basically blood clots. Blood narrows, intervessel diameter, restricting flow. So again, the hose is getting clogged, so water can't get through, right? So vessels are getting clogged, so blood can't go. It can be hereditary, it can be age, hypertension, chronic hypertension, obesity, lack of exercise, elevated blood cholesterol and triglycerides, and cigarette smoking. So it could be anything from, man, I inherited this, to I did this to myself. Right, with smoking, and then our diet, all that kind of stuff. Angina pectoris, so chest pain caused by insufficient blood flow to the myocardium. So typically due to narrowed arteries, secondary to coronary artery disease. So narrowed because they have secondary to that. So pain usually during times of increased